Today we will be examining the cardiovascular system. As usual, we will start the proceedings by first performing YP, and also we will be doing the vital signs as one of the first things that we do in the cardiovascular examination. Okay? This has been previously demonstrated, so we will then go on to the specific exam. The equipment needed today will be the following: a pen light, ruler, preferably 2, ophthalmoscope, and your stethoscope. Good. So we will first start with the positioning of the patient. The patient should be recumbent with head raised about 45 degrees. Some murmurs are accentuated in specific positions as stated in the section on the examination of the heart. Exposure and draping will be necessary in this part of the examination. The patient should be preferably gowned so that the chest and abdomen and extremities can be exposed when necessary during the examination. Vital signs, as we mentioned before, that will be carried out will be pulse, rate rhythm, and all of the necessary prerequisites, blood pressure, respiratory rate, and temperature. We will now start with the peripheral signs of the cardiovascular disease. Now, during any comprehensive physical examination of a patient, physicians save time by assessing peripheral signs of cardiovascular disease during a comprehensive peripheral examination that includes examination for peripheral signs and may occur in diseases of all organs and systems, including those that are going to be mentioned below. So we first start with the hands, and we're going to ask the patient to hold their hands forward, and we're going to be inspecting first their fingernails for the following: peripheral cyanosis, which looks like a bluish discoloration; clubbing; splinter hemorrhaging, which shows up as brown or red streaks in the nail bed. Now, the test for clubbing is the Shamrock test. You ask the patient to hold his fingers up, and you check for the appearance of a small diamond in between the dorsal parts of the phalanges. You usually check cephalon. Okay, next we will inspect the palms. So we ask the patient to turn their palms outwards, and we're going to be looking for Janeway lesions. Now, these are going to be showing up as erythematous non-tender lesions. So they're going to be reddish looking, but they're non-tender. So when you touch them, they should not hurt. Next we go on to the palpation of the pulp of the fingers, and we're going to be checking here for Osler's nodes. These are going to be tender nodes in fingers and soles and toes. So the same things that we check for here at the very tips of the fingers, we can also check for them in the toes similarly. Next, we move on to the examination of the eyes. So we're going to the region of the face now. For the eyes, we're first going to look outwardly for signs of pallor, and for that we check the palpebral conjunctivae by first lowering the lower eyelids and looking to see the color, to see if it is paler than we should expect. We are also checking at the same time for subconjunctival hemorrhages, which we can see in hypertension. So we check, and then we can also check the retina for changes of hypertensive retinopathy, for rod spots, and this is all done using the ophthalmoscope, which we are not going to demonstrate in this part of the lab because it has been done in previous labs. Good. We then inspect the face for what is called a malar flush. So that's the area of the cheeks. Remember, it is usually associated with mitral stenosis, and it should not be confused with a malar rash because a malar flush can be blanched. Then we continue with the inspection for cyanosis of the skin and the lips. This will show up as a bluish tinge, and in this case it will be central cyanosis, which is also what we inspect the tongue and the buccal mucosa for. So with this we use our pen light, and we ask our patient to open their mouth, and we inspect for a bluish discoloration in the areas of the gums, the mouth, and the mucosae. This concludes the region of the face. We then continue to the palpation of the carotid pulses. The carotid pulses can best be palpated at or below the level of the cricoid cartilage. You then assess their amplitude and waveform, which should be usually an upstroke and downstroke. And we also check to see whether or not there are any thrills or bruits heard present. Remember, bruits are essentially manifestations of turbulence that is happening at that point. We then to check for bruits, we can usually do auscultation. Good. We then proceed to palpate the trachea for central positioning. Now this specific examination is also going to be repeated, or was already done in the examination of the thyroid. It's the exact same procedure. So the importance of checking for this at this point is that it may be an indication of mediastinal shift if there is in fact tracheal deviation, because this can affect then the position of the heart. Now we continue to auscultate the lung bases for crepitations or rales. Alright, so for this we usually would ask the patient to sit up and to give their back to the examiner. Alright, the examiner will then utilize a stethoscope, preferably the diaphragm, and he will auscultate the base of the lungs while asking the patient to take deep breaths in and out through his mouth for at least 1 or 2 cycles in each side. And both sides have to be auscultated posteriorly. Next, we shall be checking for pitting edema. So for this test, we have to apply pressure on the dorsum of the foot with your fingertips for 5 seconds or greater, and then release the pressure, looking for any impression left. We'll then proceed to check the inferior to the medial malleoli using the same procedure aforementioned. 5 seconds, then observe for impressions left or pitting, and then we will do the exact same thing over the shins. And we usually try to be sure that we put our hands directly over the bones of the tibia and not the soft tissue, as it is easier to see the impression of pitting over resistant tissue. Additionally, in a bedbound patient, you check for pitting edema over the sacrum, because that would be a declivus area. We will then, that concludes the peripheral signs for cardiovascular. We will then proceed with the examination of the heart. The examination of the heart. The examination of the heart is going to first start with the measurement of the jugular venous pressure, which is usually abbreviated JVP. Now, this particular type of examination is going to provide information on pressures in the right side of the heart and its inflow. Changes in the right side of the heart also frequently reflect changes in the venous system, blood volume, pulmonary circulation, and the left side of the heart. For this procedure, you will have to have the patient in a supine position with his head or her head, neck, and thorax elevated at 30 to 45 degrees angle to the horizontal plane, as demonstrated here. You will then turn the patient's head slightly to his or her left, with the right sternomastoid muscle being relaxed. Tangential lighting is then needed to illuminate the trajectory of the jugular vein. In this case, we'll be using the internal jugular vein. If it is necessary, you can lower or raise the head of the bed to as much as 90 degrees to facilitate seeing the top of the internal jugular vein waves. Now, in order to identify pulsations in the right internal jugular vein, the right internal jugular vein is the most suitable vein to estimate central venous pressure. This vein is not itself visible, but is behind the right sternomastoid muscle and extends from behind the angle of the mandible to just lateral to the right sternoclavicular joint. Normally there are two waves seen. This is called a double pulsation in each cardiac cycle. One, the A wave is caused by the right atrial systole and occurs just before the carotid pulse. And two, the V wave is caused by the venous filling of the right atrium and occurs just after the carotid pulse. These are venous low pressure waves. Unlike the carotid arterial pulse, the waves tend to be usually obliterated by gentle pressure just above and 1 to 3 centimeters lateral to the sternoclavicular joint, and two, they normally decrease with inspiration, what we call inspiratory collapse. So those are ways that you can verify that you are in fact looking at the jugular venous pulses. The procedure is as follows. Locate the sternal angle. It is a ridge approximately 4 centimeters below the suprasternal notch. Next, locate the highest level or meniscus of the internal jugular venous pulsations, as was mentioned above, using tangential lighting. You will then proceed to place a ruler on the sternal angle and another straight edge at the highest level of the internal jugular venous pulsations at right angles to each other. The ruler that will be used for the measurement will be the one that is actually vertical. The horizontal one just gets a level which can then be measured on the ruler. You will then measure the reading on the ruler at the sternal angle, and this will be your jugular venous pressure. Normally, you expect a reading between 2 to 3 centimeters of water. To then calculate the central venous pressure, you then add 5 centimeters to this value. We will then proceed to check for the hepatojugular reflux. For this, we will have the patient in a supine position, again at an angle of 30 to 45 degrees. Again, you will locate the highest level of the right internal jugular pulsation, exactly as before, using tangential lighting. You will then apply firm, continuous pressure with your fingers in the abdomen below the right costal margin in the mid-clavicular line for more than 15 seconds. During this time, in normal person, this test increases by 1 to 3 centimeters the jugular venous pressure, and this increase is not sustained beyond 10 seconds. If the rise in jugular venous pressure is greater than 3 centimeters and is sustained more than 10 to 15 seconds, it is abnormal and is suggestive of right ventricular or congestive cardiac failure. We will now proceed to the examination of the precordial. Inspection is the first skill that is going to be utilized, and during that skill, we take a visual comparison of both right and left anterior surfaces of the chest, and it is best done from the foot of the bed. Also, we're going to be inspecting for pulsations from the right and left sides and the patient in a tangential good lighting. We're also going to be inspecting or comparing the right and left hemithoraxes for the following: size, shape, for example barrel chestedness, scars, for example sternotomy, symmetry or deformities, for example cardiac bulge due to an enlargement or even a pacemaker, asymmetry, which can be there because of a thoracic scoliosis. We are also going to be checking the apical impulse. This normally is located in the 5th left intercostal space within the midclavicular line, but of course you will locate it as is the case for your patient and then take the appropriate location. Look for pulsations in the mitral, in the tricuspid, at Erb's point, the pulmonic, and the aortic. These points have been mentioned in the earlier part of this handout. Inspect the neck for jugular and carotid pulsations, and inspect the epigastric region for aortic pulsations, possibly due to pulsations of an aortic aneurysm or a dilated right ventricle. We will then proceed to palpation. First, to palpate to localize any tenderness, and this should be guided by symptoms of pain, which we should first ask the patient about. We'll be looking for any signs that the patient may be in pain, such as a grimace or an actual reaction. We will then localize the apex beat. The apex beat is the impulse on the left precordium or on the right side in the rare persons with dextrocardia, and this is usually produced by the systolic impact of the left ventricle on the chest wall. A visible apex beat is easy to localize by palpation, so you should inspect carefully as stated above to try to visualize it. If the apex beat is not visible, place the palmar surface of your right hand over the area that extends from within the midclavicular line to the anterior axillary line in the 4th, 5th, and 6th interspaces. You will then feel for the cardiac impulse in the intercostal spaces and not over the ribs. With the palmar surfaces of your middle 3 fingers, with the patient holding his or her breath in expiration. In a female patient, you will need to gently displace the breast or ask the patient to do so from the left precordium if necessary. In patients with severe cardiac disease, the apex beat may be displaced downwards and laterally outside the mid-axillary line, requiring that you extend the palpation area. Having felt it, try to localize the apex beat or PMI with 1 finger. If it is difficult to feel, it may be easier to do so after the patient rolls towards the left lateral decubitus position. However, this maneuver displaces the apex beat to the left. Therefore, after estimating the position of the apex beat in the left lateral decubitus position, return the patient to the supine position to accurately localize it and to measure its location. Please document the location as the intercostal space and relative to the mid-sternal point or to the midclavicular line. An example of this will be 5th left intercostal space 6 centimeters from mid-sternal point, or 6th left intercostal space 1 centimeter lateral to midclavicular line. Keeping your fingers on the apex beat, carefully count intercostal spaces beginning from the sternal angle or angle of Louis, which articulates with the second rib inferior to which is the second intercostal space. This is how you do the location. Displacement of the apex beat downwards or outwards from the 5th left interspace in the midclavicular line may indicate cardiac enlargement and or hypertrophy. Please note also that the diameter, the amplitude, the duration of the apex beat. Normal diameter is less than 1 inch. So all of the following cardiac areas should be accurately located, as mentioned before. The aortic should be in the right second intercostal space. The pulmonic should be in the left second intercostal space, parasternally. Erb's point is the left third intercostal space, parasternally. The tricuspid is the left fifth intercostal space, parasternally. And the mitral will be the cardiac apex, which was just located. Bearing these positions in mind, we're going to do the following. First, we are going to palpate for pulsations and thrills in all of these cardiac areas. We start with the palmar surfaces of the MCP joints of your hands. And thrills are actually palpable murmurs, usually of grade 4 out of 6 in intensity or greater, and they tend to resemble the purring of a cat. You will also palpate for thrills in all these areas, as well as the pulses, alternating between the tips of your fingers and the palmar surface of the MCP joints. We will then palpate for right ventricular heave along the left sternal border. This is the left parasternal heave, using the ulnar surface of your hand. We will then palpate the abdominal aortic and right ventricular pulsations by placing the palmar surface of your hands and palm flat in the epigastric region. If you feel a pulsation below your hand, it is most likely the aorta. This specific procedure is also going to help us to distinguish whether or not we are in the presence of an aneurysm or an enlarged right ventricle. If you feel the pulsations coming from below the rib cage towards your fingertips, it is due to the right ventricular hypertrophy and or dilatation. If it is coming from below, then it more than likely is due to an aortic aneurysm of the abdominal aorta. We will then proceed to percussion. This is useful to estimate the cardiac size and should be interpreted with the information obtained from the position of the apex beat to percuss the left border of the heart. If right-handed, place only the middle finger of the left hand, which is the pleximeter, in the anterior axillary line in the left third intercostal space. The intercostal space can be located as before, starting at the angle of Louis. Use the middle finger of the right hand to tap the pleximeter finger twice. The tapping movement should come from the wrist. Each tap should be identical to the previous tap. On completion of each tap, the plexor finger must not be touching the pleximeter finger. The percussion note should be resonant. Continue percussing medially towards the mid-clavicular line until you hear dullness. That should be the left heart border in the third intercostal space. This maneuver is then repeated in the fourth and fifth intercostal spaces, and this will serve to locate the left border of the heart in these three spaces. Right. To percuss the right border of the heart, we start in the right mid-clavicular line and move towards the sternum. Use the same technique to percuss, starting the third intercostal space, percussing towards the mid-clavicular line, the fourth intercostal space, again toward the midline, and the fifth intercostal space. The right border is normally at the sternum. Percussion is a form of resonance to dullness, and the pleximeter finger should be placed parallel to the edge of the organ or mass that is being percussed. That concludes percussion. We will then proceed with the final skill, which is auscultation. Skilled cardiac auscultation has moderately high sensitivity and high specificity for detecting valvular heart disease. Auscultation is most informative after the preceding parts of the examination are properly done and evaluated. Stethoscopes. Traditional and older design stethoscopes have a separate bell and diaphragm. The bell is better for hearing low frequencies and sounds, and the diaphragms for higher frequencies. Most recent stethoscopes combine these functions into a single surface, such that the intensity of the pressure on the skin determines whether the stethoscope functions as a bell or a diaphragm. Lighter pressure facilitates lower frequency transmissions and vice versa. Be aware that superficial scratchy sounds may be caused by friction between the diaphragm and the skin, especially in hairy patients. Insert the earpieces of the stethoscope pointing forward in the direction of your external auditory canals or towards your eyes. Verify that the stethoscope is functioning by gently tapping on the diaphragm and or bell and listening for the sound. First, you must identify S1 with certainty. S1 is usually best heard at the cardiac apex with the diaphragm. Therefore, beginning at the cardiac apex, which is the mitral area, auscultate with the diaphragm or equivalent of the stethoscope. The index and middle fingers of your left hand should be then placed on the carotid pulse at or below the level of the cricoid cartilage. To identify S1, which is simultaneous with the upstroke of the carotid pulse. Listen for heart sounds 1 and 2 with this diaphragm. Ventricular systole extends from S1 to S2, and ventricular diastole extends from S2 to S1. In persons whose heart rates are less than 90 per minute, ventricular systole is shorter than diastole, and the interval from S1 to the next S2 is therefore shorter, and the interval from S2 to S1 is also the same. This sequence of intervals can be used to identify S1, but only in persons who have normal heart rates, because the duration of the systole becomes almost equal to that of diastole in persons who have fast heart rates. Say it again. Listen for any murmurs or S3 or S4. S3 is early diastolic sound and S4 is a late diastolic or pre-systolic sound. S3 and S4 are best heard with the bell. Note the intensity of the heart sounds, especially S1 and S2, and 2, features of any murmurs which are described below, or any other additional sounds. Heart sounds and murmurs are usually best heard at or near the anatomic areas where they originate. Continue to use the diaphragm and auscultate for cardiac sounds and murmurs in the tricuspid area, in the Erb's point, in the pulmonary and aortic areas. You'll be noting the features of the sounds and any murmurs as we just stated above. Next, we use the bell or equivalent to auscultate all cardiac areas proceeding in sequence from aortic to pulmonary, Erb's to tricuspid, and ending at the mitral area. We will then proceed with the special positions. With the bell over the mitral area, ask the patient to roll towards their left side, which is the left lateral decubitus position, and continue to auscultate the mitral area for the mitral stenosis murmur or the left ventricular S3 or S4. Next, have the patient sit up and lean forward. You're going to be placing the diaphragm of the stethoscope over the aortic area, and you're going to be asking the patient to inhale and then exhale and hold his or her breath in expiration. You auscultate in expiration for accentuation of the diastolic murmur of an aortic regurgitation. The same will be repeated for the Erb's point. The following is a list of normal and pathological heart sounds. This concludes the examination of the cardiovascular system.